They are actually sort of inspiration and instrumental to bring us and interact with you who are the ongoing MCH students. Personally, I just want to tell you that my training, which I did from CMC Vellore, and there I got the last opportunity to teach the PGTs, means my juniors MCH, way back in 1996, 97. After that, I probably have not, addressed a dedicated group of MCH students. So it's a great opportunity. I feel it's an honor for me. And I really enjoy, people to teach, to interact, and to also share your newer ideas with us because it will enrich us. Appropriately, the CABG, which is the bread and butter of cardiac surgery, so it was very important to start with this subject. And he has given me a sort of various options regarding CABG, which I would like to talk. So I thought the best is to start with the indications, decision making, and contraindications of CABG, because once you pass out from this place and branched out into the practice, this is the first thing you will face in your day-to-day clinical practice of cardiac surgery. Now, indications, if we are talking about, once we are talking about indications, before that, I would like to actually make you very comfortable that there are a variety of recommendations. But what are the recommendations? What are the society's recommendations which you actually should concentrate? One is the standard American Heart Association, ACC guidelines. Second is the STS, Society of Thoracic Surgeons guidelines. I would say why? Because that is a platform which actually is honest. You will not say it's overseeing the interest of cardiac surgery, because we feel, which we will come to know in 2021 guidelines, that slowly ACC and AHA is becoming a mouthpiece of a cardiologist. So we need to know what is the correct indications. So Society of Thoracic Surgeons guidelines. And thirdly, there is a bit of unanimous decision making in Europe. So the last guidelines which they have floated is between the European Society of Cardiologists and EACTS, the European Association of the Cardiothoracic. That's the joint guidelines. So at least they have come to a consensus. So we will just know all of these guidelines shortly, because that will enrich you and it will help you to take a proper decision making. But as we go inside, we dwell upon it. This first slide is very important. Here there are 4 indications. And I tell you, as a cardiac surgeon, this is your territory. Nobody should touch this area. No cardiologist actually should touch this area. But interestingly, they have conveniently modified their guidelines to encroach in this. So let us know about that left main disease, LMC. They call it unprotected LMC. So that is our territory. Diabetes with multivessel disease. This is our territory. Ischemic cardiomyopathy, even with 30% or less. If it is irreversible cardiomyopathy, the game is over. But if it is a reversible ischemic ICM cardiomyopathy, based on Stitch trial, it is our territory. And of course, all the complex multivessel disease with anatomical complexity, which is the basis of the syntax score, that is also our. So keep in mind that these are the 4 clear indications on the basis of which our cardiac surgical practice of CABG is based. Now this slide is nothing, just it gives you just a viewpoint to understand that this class 1, class 2, class 2B, class 3, this different color code. Because this is important to understand that what is in green, what is in yellow, what is in orange, and what is in red. And on the right side, you have got the level of evidence. So level A, level B, based on randomized trials and different evidences. So wherever you see green signal, that is our territory. So with this background, we move into the CABG guidelines. The basic foundation is on 2011. That time they come out with an exhaustive guideline, and over the years, they have just added, they have just included one or two extra things. But this is the foundation, 2011. And from there itself, they have highlighted that there should be a role of a heart team. So it is green. And calculation of the STS and syntax scores, they have not made it mandatory, but put it in the two-way indications. And SIHD is a stable ischemic heart disease. Now there is that yellow followed by a deeper version, orange, and then there is the red. If you just go through this slide, this 2A, 2A, 2B, whatever is in the yellow side, this is giving you an ambiguity between PCI versus CABG. So they are very clear. When the syntax score is less than 22, they will take. When the syntax score is intermediate or they are in trouble, they will give it to you. So they have cleverly put this as 2A and played the games evenly for the both sides, for the surgeons and the cardiologists. So you should not feel ashamed to touch any of these patients with even low syntax score if the patient comes to you, because as we go in this discussion, we will come to know that the long-term benefit of cardiac surgery, CABG, versus PCI is never been highlighted. So even with a low syntax score, if you do a CABG, the long-term results are better. But that has been always suppressed by our cardiology colleagues because they are making the guidelines. So this 2A, 2B, 2A up to these are the ambiguity. Now you go to the 2B where, again, they are very cleverly mentioned that whenever the syntax score is less than 33, yes, PCI can be done. But ideally, it is a surgical territory. So bifurcation, left main, CAD, syntax score of less than 33. These are the areas which they have kept it in their side. Also, there may be some patients which are not very good surgical candidates, like who has got a severe COPD, they have got a prior stroke, prior cardiac surgery. So there, we surgeons have to be clever because there the syntax score is less than 33. You rather push the case to the cardiologist rather than doing yourself and unnecessarily creating a mortality. Not because of your fault. Your revascularization techniques were perfect. Surgery was the best. But this case was pushed by cardiologists to your side. You rather push the case back to them because by the recommendations, it fits in that you can also do a PCI. You can solve it. And of course, when we come to the stable ischemic heart disease, where, there's an unfavorable anatomy for PCI and who are good candidates for CABG, even this is harmful. So this is the third category where actually you should avoid doing CABG. This is the third one. So be very clever about that. So these three things you have to keep. First is that there are certain things which is easier, which cardiologists want to do. There are a little difficult part which cardiologists try to push on your side. But when you are practicing, you become very clever that the syntax score, if it is in the intermediate zone, and there is a comorbidity for your cardiac anesthetist also to guide your surgeons that you also put a red flag. The better push this case back to the cardiologist. Let them do a PCI on this rather than do a surgery. This is the next slides, the same guidelines. You can see if there is a 3-vessel disease with or without proximal LAD. So green signal is for CABG. And 2A is also for CABG. If there is a complex 3-vessel disease, syntax more than 22, why you will not take the case? Why you leave it to take only the syntax more than 33 to accept as a surgeon? So 2A is a clever indication for a cardiac surgeon to accept the case because you are taking a good case. And PCI, they have already said 2B, you got an uncertain benefit. 2-vessel disease with proximal LAD, also our territory. Many times cardiologists say 2-vessel disease we will do. But if the LAD is involved, it is our territory. 1-vessel disease, interesting. With proximal LAD, you have a score over cardiologists when you promise them to use Lima. So Lima on LAD with a single vessel disease, also 2A indication for us. PCI of uncertain benefit. 1-vessel disease without LAD, yes, we should not show any interest. It is CABG or PCI, whatever they want to do, at least we will be not doing a CABG in a non-LAD single vessel disease. And next comes the area of LV dysfunction. So as a cardiac surgeon, all of you should be ready to face that whenever an echo is done, don't expect a clean figure of 60%. Most of the time you are landing with 45, 35, 30. Are you panicked? I will show you in the later slide. You need not have to be panicked. You have to understand what is that EF 30% means in real terms. Don't see the number. You have to analyze that 30%. You have to understand that 30% EF or 35% EF come under the domain of cardiac surgery, not for the cardiologist. So 2A indication for 35 to 50% is ours, and 2B less than 35% is also ours. And PCI, there's no data. So be prepared and ready to deal with low EF CABG because this is our field. You cannot say that I'm getting bad patients. All our patients are having low ejection fraction. No, it is our job to sort it. But later on the presentation, we will discuss that what are the low EF you should be beware of, where you should touch and where you should not touch patients. And then the last two indications are the survivors of cardiac death with presumed ischemic mediated VT. This is a very serious situation, but you have to understand that if a patient has got a sustained VT which led to sudden cardiac arrest and patient has revived, then maybe his myocardium is dying for US. So, of course, with a high risk, if you revascularize the territory, suddenly everything will be okay. So that's why the indication is again green for us. So as a cardiac surgeon, we have to understand that why the patient has got a sudden cardiac arrest, why he had a VT, and when he was revived back, so some amount of myocardial blood supply has been restored. So patient was in that context revived. So there is an option for revascularization if his coronary anatomy is good enough. So these are the 2011 guidelines. These are the basic foundations. Later on, a lot of guidelines have come. We will basically make our whole foundation on this 2011 guidelines. Now in 2021, ACC and AHA, they revised. In the mid, there are a couple of guidelines came, but they keep an eye on this 2011 guideline and they made significant changes. And interestingly, they attacked surgical revascularization. So stable multivessel disease with normal EF. So you're getting a good patient. So the recommendation they have smartly changed and downgraded to class 2B. Saying that, with medical treatment and all that, even with PCI, the results are comparable. Okay. So this is very unfair because you are getting a good patient, triple vessel disease, normal EF to perform, but a cardiologist slightly comes and tells you it is not an indicated for you, it is 2B. Second was the proximal LAD stenosis. CABG for isolated proximal LAD stenosis without multivessel disease. Again, they downgraded to class 2B, where you are going to put a nice lemma. But cleverly, they will put the PCI first rather than a CABG. And thirdly, which is also not their business, they put radial artery conduit as the number 2 conduit after lemma, which I think they have no right to do so. Because radial artery is a tricky artery, we all know. We have to know which is the area where to put the radial artery. It is prone to a lot of things, spasms. You have to know how much is the stenosis. How can you make it number 2 when you have got the age-old saphenous vein artery? So this is all their recommendations. So there has been a lot of protest from the Society of Thoracic Surgeons in the US. And interestingly, our body, ISCTS, with Dr. Sarkar and many people, Pradeep, and a lot of from West Bengal and from many from our India, they put a strong rejoinder and sent this letter back to the ACCHA. So Indian viewpoint of cardiac surgeons after these 221 guidelines. So surgery, so Society of Thoracic Surgeons, these people have given the objections I will show you in the slide. But society STS people, they have based their guidelines on ACCHA of 2011 fine. But on 2016, from surgical point of view, they have recommended certain things. And we all know about it, but it will give you a lot of confidence that STS, such a big society of America, they are saying LITA is the gold standard. So it is a gold standard, it will remain a gold standard. Beta is recommended for a patient without excessive risk of sternal complications, where severe obesity, poor control, diabetes is not there. Beta is beta. So go for beta, bilateral internal mapping. Third thing they have said, they have all understood, which we'll discuss, is the skeletonization. Skeletonization reduces sternal infections. We all know about it. We'll discuss it later shortly at the end of the presentation. And the spasm management, they have recommended that you use calcium channel blockers, whatever is available in your theater, to reduce the intraoperative spasm. So basically, they have focused their whole thought process in, as a surgeon, what we should do, how to better our outcomes. In 2021, from 2016, STS again has gone through the whole things. They have said the revascularization choice. Now, they're being a little liberal. That between PCI and CABG, we as a surgeon, if we want to score over PCI, so we have to do more quality work. So they are focused more on technical arterial grafting so that we can overcome the hurdles which is posed by our cardiologist friend to give a better outcome in a patient. So that is the focus of revascularization choice. And another important thing over the years has emerged is the minimally invasive surgery. Minimally invasive surgery, we know that it is a huge range. It is, if we start a minimal invasive from the level of incision, and if you start saying what is the ideal minimally invasive surgery, then probably the thoracoscopic and robotic surgeries are the actual real minimally invasive. So that's a huge range. But the important thing is that they are very interestingly told that from 2015 to 2022, when this technology was evolving, the surgeons have started practice. This contribution is only 0.5%. So that means that there is a lot of room for improvement. Lot of growth is required in the minimally invasive surgery and that field, so that we started doing more surgical approach to be minimally invasive over the years and come out from our conventional. So this is 2021. Now this is that American Association, they put the objections. They said, how can you downgrade a CABG in the treatment of TBD? Very strong objection. Second, there is no, evidence. You have not highlighted the long-term benefits of CABG versus PCI in decreasing the repeat reinterventions and post-procedural MI, which quietly our cardiology friends suppresses. Because you will never know one PCI followed by 2 years later another PCI. There are many patients dying in their home due to SAT, subacute thrombosis of the stent, which is a very peculiar situation when the patient complains to their relative that I'm not feeling well. That means the stent is slowly getting blocked. And one day the patient popped up. So best part is the patient never reaches to the cardiologist and nobody to be blamed, not like our cardiac surgeons. So this is another important thing which we should realize, that this is the second objection from the American Association of Thoracic Surgeons. And thirdly, why a radial artery as put as a number 2 conduit, CABG conduit, without a overall STS, recommendations, and they are taking their opinion. So these are the 3 things which you people should know. I'm going to a ESCTS also to review what the Europeans think about us, about our cardiac surgery. So they were actually the people who formulated syntax. So they are evolving everything around syntax. So they have made very clear that if you got a left main disease, it is your territory, fine. Then if the syntax score is low and you have got a LMCA disease, what you are doing? So they made it very clear that ball is in both courts. You can do a CABG or you can do a PCI. So there were green indications for both. Left main disease with intermediate zone 23 to 32, PCI as 2A, still number 1 CABG. They are at least honest enough. Third, LMCA with high syntax, no question of PCI, it comes into our domain, so it remains green for us. Now, triple vessel disease. Triple vessel disease without DM, diabetes mellitus. Syntax score low, it is ours, and now cardiologists will not leave that they were already doing it, and in the 2021 they downgraded it to 1B. So here carefully, if you see the European recommendation, both are 1-1. Both are green. Triple vessel disease with a high syntax score, intermediate, that is the zone where they are honest enough to accept that CABG is best. Rather PCI, they have given it harmful, 3. 3 vessel disease with DM, both 0 to 22 syntax, more than 22, it is ours. So this is a very good slide. I mean, these slides gives you the confidence that this is your territory, you should operate on these patients. Next comes a very controversial area of cardiogenic shock, STEMI, and STEMI. I'm not detailing it, but STEMI is mostly comes onto the domain of PCI. Only area where they have given a green signal, where an emergency CABG with a good coronary anatomy, which is amenable to us for not for PCI, this has been given the green signal. So when you are accepting any cardiogenic shock, be very clear how is the coronary anatomy. If the coronary anatomy is deceptive, some of the coronary anatomy may be difficult for the cardiologist to stent. For surgeon, it may be easy. But if the coronary anatomy is showing some diffuse nature of disease, already a patient has got a full staining, don't touch them. So this is where we are into this area. So key areas, ESCTS guidelines 2018 and 2022, they have done a review. What are the things which has emerged? First is the emphasis on a heart team. So they have realized that both cardiologist and the surgeon should sit together. Syntax score evolved. Diabetes mellitus for CABG consensus statement. Functional assessment by FFR. So this is a good thing. Many times a cardiologist give you a angio and say that, I think this is a triple vessel disease. Some interest, they are pushing the case towards the surgical side. You review the angio and you are not very convinced that the LAD artery looks 60%. In a different views, if you take, it is looking maximum 65%. Are you going to graft? So you can ask your cardiology colleague if FFR is available. Why don't you do an FFR on us, on this patient, and tell us the exact data? So if the FFR shows that there is a significant fractional flow reserve and there is a significant obstruction, you should accept the case. So this is another catchment area, which this vague area, gray area, where you should be cautious. Surgical technique, they have again emphasized the use of multiple arterial grafts. 2022 review, mainly this is on the left main disease, which we have shown it. Stable LMCA disease, they have given the choice for both PCI and CABG in a low risk anatomy. With a high syntax, it is ours. But CABG remains a strong class 1 for a complex LMCA disease with complete revascularization. Now, I'm showing you these two angios. Now it's an interactive session. So what you are seeing in this angio, and I will go back to the previous slide. What about the LMCA? I think it should be very obvious. It's a very good angio. Huh? Which part of the LMCA? So that is a very important. That matters. So this is a distal LMCA with ostial LAD involvement, ostial circ involvement. Now go back to the previous slide. Comment. This is also LMCA, but which part? No, almost proximal LMCA. There is a damping there. The dye, the catheter, they are not able to negotiate. So there is a damping. You can see the regurg of the dye. So this is a proximal LMCA. Now my question is, you have a cardiology colleague who comes to you quietly, and out of these two angio, which angio he will give smartly to you to operate? First one, he will offer you to do. First one is the distal LMCA. So I think I agree with him. So he is in the correct domain. Distal LMCA they cannot handle, because you can see in that last, this one, that there is a ostial LAD, the SARC. The moment they engage the catheter, severe hypotension, cardiac arrest on the cath lab. So they will never touch the patient. Proximal LMCA, they will keep it for themselves. But for a cardiac surgeon, it's a great thing that we can handle both proximal and the distal LMCA. So what I'm trying to say is how the things are being manipulated. The things which come to you, which they cannot, you understand. So you have to understand the thing and understand it very well, that when they are giving you the case, what is the motive behind it? Because you are a clinician, you are not a cardiac surgeon first, that are you going to give real benefit to the patient? Little bit of syntax score. Syntax score is the tool which I said evolved in Europe. And it is basically an anatomic score of the extent of coronary artery disease. And what is the coronary artery disease stenosis level? Anything above 50%. So they start calculating. But they have kept so many parameters. In the next slide is even better. You can see they start with dominance, coronary segment, total occlusion, trifurcation, bifurcation, aorta ostial lesions, severe tortuosity. These are the numbers. Length, heavy calcification, thrombus, and finally diffuse disease and small vessels. So on this basis, they have got a syntax scoring system, almost computerized, because when they see the tree, this tree, coronary tree, this is AHA, American Heart Association coronary tree classification. They have provided. There is called a Lehman score, lesion specific characteristic. They are all taken into account, bifurcations, occlusions, and finally the scoring is done. We are, by this time, everybody know what is the low score, anything below 22. Intermediate between 17 to 22 is the intermediate rather. Anything below 16 is the best. And 22 and above, 32, 33 is the high score. And high score means CABG. So this is one way of accepting that there is a complex anatomy. And in the complex anatomy, the best course left to a patient is a CABG, surgical revascularization. This slide is also very important. Low syntax score, intermediate syntax score, high syntax score. You can see that yellow one is basically the PCI. The blue one is the CABG. And as you see very clearly, you move from low to high, the divide, the gap between the PCI intervention and CABG widens. And what is widening is the cumulative event, that is the massive. As you are moving towards more dangerous territory and you're still persisting with a PCI, the results are so bad. In the third slide, when syntax score is more than 33. But if you do a CABG, it still remains 17.9%. It's so heartening for a cardiac surgeon to know and accept. So this is a very clear-cut slide, proven that over the years, the massive will go up when if you are dealing with a high syntax score and you have not subjected the patient to a bypass rather than a PCI. Next is all of you should be knowing is the risk stratification. Well accepted Euroscore 2 calculator. In our hospital, it is a mandatory to put a Euroscore sheet in all the patients because that is being audited. So, and if a patient has got an adverse outcome, then also in our mortality meeting, the Euro score has been asked. And if it is a high Euro score, they ask that whether we have properly counseled the patient to the patient's relative. So it's a very easy, I think everybody knows this. And you people should get this Euro score here in your laptop. And for any CABG you are doing, in the morning use yourself, from the age, biological sex, chronic lung disease, yes or no, just you keep on putting it. The moment you put it, finally the Euro score comes at that point where it is 0.00%, where actual Euro score will emerge, and you can submit it. That becomes the patient's Euro score. So you'll be amazed to know that many of the Euro scores are low in spite of complexity of the problems. But Euro score goes actually very high, interestingly, with the comorbidities. So it is good that comorbidities has given a lot of weightage in the Euro score, and which actually saves the skin of the surgeon. That my patient which I am doing CABG is fine, but you see the amount of comorbidity. That's why the Euro score was high. So we have told you that outcome can be borderline, not because of my operations, because of the associated comorbidities. So this is very important. And with this, we have more or less covered the indications. Now, as we decided to discuss something about the decision making. So that is a more interactive area where we can discuss the things. And this is an important thing, that any mistake in patient selection can lead to a bad outcome and mortality. To sort out, we need further investigations. You have got these modern investigations. Thallium scan was there. I've got a cardiac MRI. We have a PET FDG scan. I think in SSKM also now things must be made available in our hospitals, especially it is there. So I just guide you, trying to discuss with you how you will take up a case. Now, here we are moving into that area where there is a low ejection fraction. Now, interesting. A echo report comes, it is interactive, and they say that ejection fraction is 28%. And there in the lower part, they mention severe hypokinesis. Will you accept the case, yes or no? Further investigations. What further investigations? What are the further investigations? Why you want to do a perfusion scan? Right. See, echo is good enough to tell you a very important thing, which we are going to discuss, is that what is the status of the myocardium? Whether there is a kinesia, whether there is a thinning, this information you will get from the echo itself. What is this echo suggesting? That there is a generalized global severe hypokinesia. The heart is not moving, but heart muscles are there. As a surgeon, I will accept the case. I'm not afraid of a 28%. It's a very important thing, all of you to get this. So that's why I have put the next slide. And this next slide is of the echo. In this echo, this all, the arrows are pointed towards a very important part of the septum. It's the proximal ventricular septum. When they comment in the echo, the EF is 32%. But they also mention that proximal interventricular septum is thinned out and akinetic. You people should be alarmed. Don't touch the patient. Shubhendu, you agree with? Yes. Because proximal septum with a loss of AJ, Daksaki, good afternoon, thank you. So proximal septum is a most important part of the LV geometry. So if the major septal has gone, whenever you will do a surgery, you will be never able to restore the LV geometry. A portion will maybe dyskinetic. Patient will probably never come off from the OT or later on in the post-operative, even with the intra-aortic balloon pumps. So it's very important to understand that akinesia is not the word which we are frightened. Which territory it has gone? If they reverse the finding, say they say 29% EF, but the akinesia and thinning is involving the distal septum, will you accept? Yes. With a high risk, I will accept the case. Because I know that if we're putting the graft on the distal LAD territory, patient will finally come. We might have to put a vein because his LV geometry is maintained. So that's why I have included this particular slide. But the problem comes when the report is a little vague. Low EF with informations like one of the territory, say infrapostural, some wall is akinetic, thinned out. Anterolateral wall distally or the side of it is akinetic, thinned out. Then what you are going? This is the time you take help of the thallium scan. Basically, in the thallium scan, what you are looking for? You are looking for the hibernating mark. They will comment that there is some area which is gone. Fine. With your revascularization, it will not come back. But there is area which is hibernating. And if it is a significant area, you will accept the case. So that's why you want the thallium scan. Now, there are a scenario one. Patient has suffered a recent ASMI, admitted in hospital. Coronary angiography, 100% total occlusion of LAD. Evidence of triple vessel disease with a non-dominant RCA. Echo showed 28%, akinetic anterolateral and ventricular septum. That is on this hospital admission. Somehow, based on medication, cardiologist has shown you the angio and the patient has left the hospital. Maybe he was frightened, not ready for surgery. You have not said, yes, patient gone home. Come back after 3 weeks with breathlessness. And this time, patient is very unstable. And he is requesting for something to be done, a CABG. And probably he has come and visit you in the chamber because knowing that cardiologist may not push him. Latest echo has improved from 28 to 33%. But there is some change. And you can see what is that change. So there is a thinning of ventricular septum. Rest of the wall thickness preserved. Thallium scan shows same findings. Anterolateral wall and proximal ventricular septum scarred, non-violent. Don't touch it. These are the decision. Okay. 3 weeks he has waited. You may ask, sir, what happened when the first time the EF was 28 and that time it was showing akinesia only? Because it takes some time, the scar to take place. Immediate the first day when the MI takes place, EF will be less. When we will examine the different segments of the myocardium, regional wall, the muscle thickness is maintained. So don't be fooled by the first week. After 3 weeks, the game has changed. So you have got certain more tools. You've got cardiac MRIs. Cardiac MRI can give you even very fine informations. Like if you have a territory where there is a thallium is saying that, there is a least uptake, means viable, hibernating, mildly viable, a bit of confusion. Cardiac MRI can even give you a fine print of that. And that is known as this late gadolinium enhancement, LDE. This is a special case with cardiac MRI people are doing. Here you can see that the single arrow is the area of anterolateral wall. There is an enhancement that's more white. So that is 50% chance of viability there. That will come back. And the apical area, the big arrow, there is less enhancement. You can see that area is a black area. Beyond this big arrow, if you can see in my laptop presentation, it is much clearer. This is the area. Can you see that? And here is that, you can see less enhancement. Now, will you accept the case? I will accept the case. Why? Because I know my anterolateral wall is also there. A small apical part is gone. So I will accept the case. But if the reverse, the major anterolateral area is showing less enhancement and that apical area is showing some amount of enhancement, I will not accept this. So these are the fine prints. And finally, you see this particular angio, deadly angio. I think everybody would agree. See the amount of diffuseness of disease on the right system as well as the left system. So this diffuse coronary angiography, when they have done and come out with this sort of angiographic results, again, cardiologist pushes very hard towards our side. There's no options, doctor, left. Only CABG kora jete pare. That is the only thing we can do. Kichu korun patient er jonno. So again, you have to understand what is the trick, where is the problem. I show you the problem. This is a patient has suffered a recent MI, diabetic, previous history of inferior wall MI, having a repeated heart failures. NT-proBNP high, 13,000 in the first admission, requiring repeated invasive, non-invasive ventilation, coronary angio, 3-vessel disease, echo low EF 30%. Will you touch the patient? Now the problem is that in between that intervening window, when the patient is not being under NIV or invasive ventilation, cardiologists may quietly push the case to him. And they will just give you an information, low EF, bad anatomy. Patient went into heart failure, which you will accept. But they are not saying in this last 7 days admission, 2 times, 3 times he has to be put back on NIV. The moment they are withdrawing the NIV, he gets decompensated. That information is not shared. So you happily accept the case, counsel the patient that I am doing the surgery with full faith that my revascularization probably would help the patient. So you are, my friends, are caught in a very bad mess. Repeated heart failures. That means probably he has reached an irreversible ICL, ischemic cardiomyopathy. And importantly, all of us should understand that there is, beyond the epicardial arteries, there is a microcirculation. And for a diabetic, you know, in the legs, in other territories, the microcirculation is a problem. You can have a normal, good arteries, but the problem is that they will have a distal toe disease. When you do a peripheral angiography, you see the femoral is fine, popliteal is fine. Below there, your anterior, posterior, peroneal arteries are diseased. What is the treatment? Nothing. You put him on peripheral vasodilator and say, thank you. You cannot do a revasc. Similarly, in the heart, there is an entity of microvascular circulation, which you can't see. Because as a surgeon, we are doing the epicardial. So what is the investigation? Now you have an investigation which can give you an information of a microvascular status. And that is a PET CT combined with CT. You can see in this tree that upper one, everything is fine. In the lower part, the epicardial arteries are fine. But as it is going inside the myocardium, the microvascular territory is diseased. So in the PET scan, you can see that healthy blood flow region is that the yellowish tinge, and the blackish reduced tinge is the area which is the micro circulation which they have picked up with the help of the PET CT scan. So what I'm trying to emphasize that if somebody press you hard, you have got the modern tools to go far and prove that you are correct. Many of our colleagues and surgeons, we have burned our fingers doing this case. Tragic part is the outcome. I tell you what happens, that when you do this operation, the patient will come out on IABP. Interestingly, in 1 or 2 days, he might come out of IABP. But inside the ICU, within 3rd, 4th days, he will develop respiratory distress. You will put him in IV, give lot of diuresis. But interestingly, at that moment, you cannot introduce heart failure medications, which you have the ARNIs because of the low BP and the creatinine issues. So you cannot improve that heart functions, number one. And patient will go on and off into NIV, normal NIV, back to, and finally maybe to ventilation. Then there will be a discussion in our hospitals and areas, why you have done this case. There's a medical board. Then we come to know, when we start talking, that this patient probably would require transplant. And only way to save him is a bridge to transplant. So you have to probably introduce a MCS, mechanically circulatory device, support like LVAD for this particular patient. That's the only option till the heart is up. So I'm trying to say that these things are all CABGs, but some of them can be so dangerous and so deceptive. So this is how we have to understand this, that I've given you a couple of scenarios. And finally, the contraindications of CABG, I've made it very simple. 2 things. You have got no coronary arteries to graft, means incompatible. You have nicely reviewed the angio, you search an area, you find nowhere you can graft. So even a person who has got a good LV function, you will reject the case. Other way around, patient has got a good epicardial coronary arteries, but no viable myocardium, which you have proven with the help of thallium scan. What we are going to reperfuse. So these are the 2 broad contraindications to say no to the CABG patients. So with this, we have covered our presentation, but beyond this, do we have some time, Shivandu?
Yes.
I just want to touch certain small surgical tips and techniques which we are doing, so that these are all theoretical aspects of accepting the case. But you know, when you become practical in your field, then what are the things, how you will decide, what are the graphs, where to put. So we'll give a very basic general discussion. So irreversible ICM, you work up the patient for cardiac transplant. Now, basically coming to this issues like on-pump CABG versus off-pump CABG. You all know that when the off-pump CABG came, there was a lot of resentment between those who are doing on-pump CABG, that the results are borderline, a lot of Ruby trials, a lot of things came. Then later on, they all confided, they know it off-pump CABG also in good hands, the results are good. And when the surgeon become experienced, so that word which was spread that we are doing incomplete revascularization, people become so experienced that they are going 5 to 6 grafts also on off pump. So that issue is now settled down. What I'm trying to say that on and off pump is a great tool in our armamentarium. We should utilize both methods judiciously. If you ask me, the second thing is the MICS CABG. Why I'm put it in my context that I can now claim myself as a minimally invasive surgeon. That much of minimally invasive work I'm doing in my app. Out of 10 CABG comes, probably 7 cases will go MICS. And I'm talking of multi-vessel analysis, where we are going up to put to 2 to 4 grafts with the 2 top ends. So we are doing a complete revascularization. But what I'm trying to say very clearly that I am not shying off from on-pump CABG. I do reasonable amount of on-pump CABG, reasonable amount of off-pump CABG, and the condition which we can discuss in some other opportunity for MICS CABG where to perform MICS. What I'm trying to say, these are the options we are all having these new generations. So all of you should be focused that you should be master of all the 3. Because if you become only master of MICS by chance, and you don't know how to perform on-pump CABG also, which looks ridiculous. So you have to be good in all the 3 things and utilize these 3 methods in context with the different scenarios. Now, scenario number 1, where you'd like to do an on-pump CABG. When I see a patient who had got an unstable angina previous night, coronary anatomy deadly, LMCA 99% distal, right coronary 90%. Frankly, I don't have a confidence in my cardiac anesthetists that even pre-anesthetic induction crash can happen. I will tell my perfusionist, get ready your pump. The moment patient anesthetized, sternotomy, take the purse string, put even the aortic and venous cannula, and then you sit down and take the lima for the time and energy. This is the safest way to play the game safely. First of all, we have to save our back. We cannot lose the patient in adventure. Many have said, I can perform it off pump. No, this is a deadly case. So there is a rule for. Now, there are certain techniques we are adopting. Once a critical LMCA disease, the most important graft is the LAD graft. So if we take the lima, we put all our pump ready, cannulation even done, we try doing lima LAD off pump, which is easy to do. Only your cardiac anesthetist has to maintain. Many times we have seen that after the grafting, the heart has become reasonably stable. Then probably you can manage a ramus or probably a PDA without going into pump. But there may be an OM which is very proximal near the groove. So what I will do, everything is ready, I'll go for a short bypass. Nothing is lost. 20 minutes job, safe, do a complete revascularization without any hypotension, any event in the theater, and patient is fine. So practically what you have achieved? You have achieved a very short exposure of only 20 minutes of CP bypass to the patient instead of full bypass which you have. So this is can be one of the strategies. Off-pump CABGs without which we call beating on. We don't pleach. Actually, now it has become problematic for us because all of these modern day surgeons are using intracoronary shunts. So with pleach, the arteries collapses. So we are now shaky while taking the bites because we always now put shunt. So what we do, even in a pleached heart, by chance we have to do, we put a shunt. This is because of the nature of practice. So anyway, now come to the selection of conduits. based on the degree of stenosis. Again, the safest conduit is your vein graft when degree of stenosis is concerned. Whenever you are in doubt, 70%, 75%, 65%, put a vein graft. The vein graft will flow. In LAD, most of the LAD which is getting blocked is, let's say, after 3 years, is that they have put the lima on a less occluded LAD. In the name of putting lima, they are putting. And the outcome is very bad. After 2 years, angio done by a cardiologist, they say your LAD has been not grown, it has become atrophic. The mistake was yours. Even the patient was young, you should have put away. So these are a very crucial decision. So degree of stenosis. Then diffuse nature of blockages. Now here I will ask, between arterial conduits and vein, which you will choose? Diffuse nature. Arjika. Very good. Why? Because arterial is mostly based on lima. If you have put a total arterial, if you have done a Y graft, again the supply is from lima. And we all know that lima has the capability of auto-regulation. Means if a territory needs more blood flow, it will give. If the territory needs less blood flow, it will auto-regulate in that particular territory, which vein graft does not understand. It booms. The blood comes from the aorta and it does not understand how much blood. It just keeps on giving the blood. And some territory where the blood is required, it is not able to push it. So this auto-regulation is present in the arterial grafts. So when you are doing a bad patient, you have to become a very good surgeon. Means you have to become smart in taking lima down, rima down, and probably you have to do a total arterial to get best results. So there is the indication. We say now who is a good top CABG surgeon is those people who in the middle of a very badly diffuse diseases still pursue with arterial grafts and get away with it. So that is the indication of a high quality CABG. Order of revascularization. Many times there is a debate, proximal first, distal first. I do both things, but I will do according to the scenario. If I feel that heart is pretty unstable, if I do my distal first and then I connect it to aorta, the revascularization is taking time. So why don't you do the proximal first? At least put one graft immediately, one distal in that territory and make the heart stable. So this is again your choice, proximal or distal first. Order of grafting. Normal lima LAD, that's the first, because LAD is the most important artery overall in the heart. So we will put lima LAD. For lima LAD, another benefit is that you don't need a top end to be done. Immediately revascularization status is restored. Then this, the methodology was that you doing the left-sided graft. Recent years, I have seen others and I have also changed that I will go by which territory is much more critically tightly stenosed. If the RCA territory is more, I will do a RCA graft first and then go to the left side. And lastly, I will touch the least stenotic, because always keep it in mind, if you are doing off pump, a flowing artery, if you occlude it for a second also, you can have disastrous problems. It's a flowing artery. So keep that artery for the last. By the time you have salvaged the myocardium, you have put the grafts in all other territories. And best surgical revascularization, debate is not there. Total arterial, bilateral bema, skeletonize, Y graft or T graft, whatever you do. One line about skeletonization. I must tell you, the skeletonization is also highly dangerous. No, people say, I'm very comfortable with taking pedicle, I will do skeletonize, very nice length, this, that. But I tell you, for beginners, skeletonization can be deadly and which you will not be able to recognize. Why? Because when you use your cautery current in skeletonized manner, you are very close to the limb. And the thermal energy is very quietly dissipated into the intimal area, into the lemma, where it can produce a thermal damage which will go unnoticed. So, what practice we have done, we have made a promise. The promise is very clear. Taking skeletonized lemma, the technique is simple. You use cautery and you push the satellite veins away from the lemma. You go away. Automatically the lemma comes. Now the branches. Once the branches are there, you clip them, but use pot scissors to divide them. Never use a cautery on the other side. This is my piece. There are people maybe doing, but I feel that I will cut all the branches between the clips with the help of a scissors, pot scissors, and avoiding cautery nearby lemma absolutely. And finally, when the lemma or the rema comes, you feel so confident. It's throbbing, pulsating, no spasm, I have also seen. So this is an important technique which I want to share. When you people go into your clinical practice, taking down a skeletonized lemma, avoid cautery between the branches. Clip them, cut it with a micro pot scissors. Sequence is also very important. When you are doing a lemma rema, you have to understand very cleverly. It's not like that you have to put it into the OM, you have to put it into the PDA. Also, you have to figure out that the last graft which you are receiving that blood flow has to have the tightest stenosis. If the stenosis is the previous graft which is tighter, so common sense the blood flow will be taken into that territory more rather than the last. And the last graft will suffer. There will be area of ischemia and post-operatively there will be. So also you have to select the territory. It's not that you have to put a lemma Y into 1, 2, 3, 4. You have to understand the degree of stenosis. And then lemma rema when you are doing, be very careful that LAD is also tight. Why? Because LAD, lemma is giving supply to the rema system. And your LAD is not occluded that much. When you're putting that lemma, the whole blood will go into the rema system. So select the patient carefully. Tight LAD also. Put the LAD lemma and the rema. So these are the things. So with that, thank you. Yeah, please.